Okay, we'll just wait one more minute as I see that participants are coming in one at a time. Okay, well, let's get started. Welcome, everyone. My name is Theodora Swift-Kohler, and I am covering health equity here in the Gender Equity and UN Rights team of WHO headquarters. And it's a pleasure for me to be chairing this event today. Next slide. So this webinar is actually part of a wider series on rural health equity. And this series is being convened under the umbrella of World Health Day 2021, which focuses on specifically health equity. And the campaign actually goes from April to April. And this webinar series is being convened between July and March 2022 as part of the overarching campaign. And the series is also linked to the 18th World Rural Health Conference of Wonca, so the World Organization on Family Doctors. It's a satellite event. And finally, the webinar series also contributes to follow up to the shared UN systems framework for action on leaving no one behind. Next slide, please. So in our last webinar in December, we focused on quantitative data and how it is very important for understanding inequities experienced by rural populations. And we saw that indeed great progress has been made. That said, there's still quite a ways to go in terms of improving health information systems to better understand the situation of rural populations. For example, of 673 household surveys in 133 countries, only 70% collected data disaggregated by urban rural place of residence and 58% by wealth. So indeed, there's much more work that can be done on the quantitative side. In today's webinar, we're going to specifically look at building on that and building on that through qualitative methods and use of mixed methods in particular. Next slide, please. So mixed methods research combines both qualitative and quantitative methods. It's more than simply collecting and analyzing both kinds of data. It's about using these approaches in tandem, in sequenced ways as well, that can enable the overarching strength of a study to be greater. Next slide, please. So WHO over the last 10, 11 years has been working specifically on conducting assessments of barriers to health services using mixed methods, quantitative and qualitative. And we've done this using the Tanahashi framework for effective coverage to illuminate the different types of barriers that can be experienced with regards to availability, accessibility, acceptability, contact, and effective coverage, really understanding the populations not reaching the services, and then those who do, who are not actually getting proper effective coverage. Next slide. And from these studies that have been done across different countries, we've really seen that the road to health differs, and that by using mixed methods, you can understand the heterogeneity of the populations. And as many of these studies actually touched upon rural areas and rural populations, we could understand the heterogeneity of rural populations and also the varying contexts that they lived in. And we could see through the use of the mixed methods how different barriers compounded and intersected, and also how the barriers may be rooted more on the supply side in terms of the health system, or on the demand side in terms of social and cultural factors that may be contributing. Can you hit next, please? And just some of those that came forward, and this is just to highlight some quick examples. We saw barriers that could be related to facilities lacking basic health products, equipment, absenteeism of staff, issues related to affordability of the health services, issues related to contextual factors like travel time, seasonal conditions, and the fact that the health system wasn't adequately responding through potential mobile services, outreach services in those contexts. Then also barriers linked to gender norms, roles, and relations that could inhibit autonomy and decision-making, access to resources, or mobility for rural women. And also some of the examples were weak interfaces with traditional medicine systems, language barriers, a fear of discrimination based on ethnicity. These were just some of the barriers that came through the use of mixed methods, which as I showed in an earlier slide, with regards to quantitative data, that quantitative is really essential, but it's the mixed methods that will help you unpack the reasons behind these differences that we're seeing in rural areas. Next slide, please. I want to say something regarding participatory approaches, as these are fundamental for a human rights-based approach to health research, and also a key part of a primary healthcare research agenda. Particularly, I want to talk about participatory action research, and this transforms the role of those usually participating as the subjects of research and involves them instead as active researchers and agents of change. And an aspect of a participatory action research that is particularly important is that it recognizes the wealth of assets that community members can bring to the processes. And so rather than having a deficit focus and a focus on the negative and what is not working, it also focuses on the wealth of assets that the communities do have and their own knowledge of entry points and opportunities to bring forward change. So next slide, please. We are very honored to have with us today a great lineup of speakers who will further talk about unpacking the causes and manifestations of rural health inequities using mixed methods research. We're joined by Natalia Houghton and Ernesto Bascolo from PAHO, the Pan American Health Organization. We're joined by Sneha Kotian from the World Organization of Family Doctors Rural Seeds Network, and then also Luke Schaefer from the University of Michigan, Ana Lorena Ruano from the Center for International Health at the University of Bergen, and of course, as this webinar series is being done in conjunction with Wonca's World Working Party, we'll have Bruce do some closing remarks. Now, I would like to please commence the panel. If you can please go to the next slide. So allow me to introduce Natalia Houghton as well as Ernesto Bascolo. Natalia is a specialist in health systems and services analysis, monitoring and evaluation at PAHO's Health Services and Access Unit. She provides technical leadership and oversight of monitoring and evaluation projects for public health and health system strengthening initiatives and analyses of access barriers in member states. Ernesto Bascolo is the Regional Advisor on Health Governance, Leadership, Policy, and Planning at PAHO. He is a Senior Advisor in the formulation of reform policies to expand access to health and is the technical lead for the implementation of the renewed Essential Public Health Functions Agenda in PAHO member states. In their presentation, Natalia and Ernesto will share experiences in applying mixed methods to analyze access barriers and policy dialogues. The studies resulted in identification of policy recommendations for addressing challenges faced by rural communities with a specific focus on maternal and child health services in Guyana and mental health services in Peru. So I'd like to now hand over to Natalia and Ernesto. Thank you.
Thank you very much.
Okay, I am Ernesto. The next one, please. In this presentation, we review two experiences in which mixed methods have been applied to analyze access barriers and policy dialogue to identify policy recommendations for addressing challenges faced by rural communities with a specific focus on maternal and child health services in Guyana and mental health services in Peru. Both case studies demonstrate how a comprehensive analysis of access barriers can be used to identify strategies for improving primary health care in rural setting. In regard to this, our objectives are the following: to identify the main barriers to access faced by rural communities in hinterland of Guyana and the Condorcanqui province of Peru. And the second one is to inform and identify policy recommendations for addressing barriers that limit access to essential health services in those rural communities. The next one, please. The context of both studies highlight the political and social factors that influence and help to understand their main challenges. In the case of Guyana, it has a relevant health policy background. This has placed great focus on health sector reforms, policy development, and other actions aimed at improving access to maternal and child health and other essential health services. The main references are the National Health Plan, the National Health Sector Strategy, Health Vision 2020, National Medicine Policy, and the National Sexual and Reproductive Health Policy. Regarding social and demographic dimension, most Guyanese, around 90%, live in the coastal area, while a smaller percentage inhabits the rural interior or hinterlands, and the community of Amerindian ancestry lives mostly in the hinterlands. This is the most vulnerable social group with the country's highest poverty levels and the lowest health indicators. And this is the specific social context of this case. Peru has committed to protecting and guaranteeing the right to health for the indigenous people under the umbrella of a more general health reforms expressed in the Universal Health Insurance Framework Law and the Comprehensive Health Insurance. But the indigenous people of Peru represent about 25% of the population, and most live in rural and hard-to-reach parts of the Andes and Amazon regions. About 50% live in poverty. Our case study focused on the province of the Amazon Condorcanqui, where 95% of the population is indigenous. It can take between 10 12 hours to travel from one community to another, and most health facilities have an inadequate infrastructure. Next one, please. The framework used in this analysis is based on the Tanahashi model too, of health services coverage. After some adaptation, our analysis uses the dimension of availability, geographic accessibility, financing, accessibility, accommodation, acceptability, contact, and effective coverage. The next one, please. This work, the next one. This work has two, as I said before, case studies, while the Guyana study focused on maternal and child health services in the hinterland and interior and rural interior of the country. The Peru study focused on youth and adolescents in rural areas of the Amazon Condorcanqui province. Both cases have observational and cross-sectional methodology with triangulation of different sources for an integrated analysis. We included three sources, household survey data on unmet needs and barriers, a literature review on access barriers, and very important insight from health officials on policy implementations and barriers to health service access. With those inputs, we concluded with a workshop with the main stakeholders to validate and to try to interpret different potential policy options. Natalia, please, your turn.
Thank you, Ernesto, and hello, everyone. So I'm going to start by presenting the results of the Peruvian study first, and then I move on to the Guyana study. So with regards to the results of the main barriers experienced by indigenous communities in the Peruvian Amazon, next, please. We will start presenting the results from the different data sources that Ernesto was talking about. So this slide here will present information from the literature review. And I would like to highlight two things before jumping into the actual results of the study. The first one is, and this is something that Theodora was also highlighting during her introduction, and it's the fact that, you know, the added value of using information based on literature review is that it allows you to have a more comprehensive view of the different types of access barriers that different communities experience. And you can see that in the figure that, you know, when we look at the different access barriers based on the Tanahashi dimensions, so you see that these communities are experiencing, in fact, access barriers along all of the dimensions of access. So there are, you know, there are multiple obstacles that hinder access to health services within different communities. And then the second one is that, you know, by analyzing based on the Tanahashi dimensions, then you can start having a picture of what can be the main drivers, because of course, you know, there is a plethora of access barriers, but then in the exercise, you need to prioritize and to try to understand what can be main things that can then further be addressed by interventions or policy actions. So with that regard, the results for the Peruvian indigenous to mental health services show that there are three main issues when it comes to the literature review. The first one is the acceptability dimension, which talks about, you know, the experience of indigenous people when they are using health services and what are their perceptions in terms of the adaptation and cultural sense of, you know, of the services that are provided to them. So there are many barriers with regards to the acceptability dimension that they experience, and they seem to be the main issues that are found in the literature review, and they relate to, you know, the healthcare providers not speaking the language of the indigenous communities, or the lack of adaptation and cultural sense of belonging in the different health services, and also the preference for other traditional and traditional medicines for the indigenous people, and also bad experiences of mistreatment, bad attitude, and stigmatization on the part of the healthcare providers to indigenous peoples, as well as the feeling of shame, fear, and lack of trust due to cultural beliefs and negative experience of indigenous communities. But then at the same time, and as Ernesto was mentioning, you know, the Amazon is per se a rural community, and therefore they also experience, you know, those access barriers that are very common in rural settings, which are, in the first part, the lack of infrastructure and health service provision in these areas. And you can see being also actually the second most common type of access barrier that is found in the literature review. And they, you know, the specific barriers they relate to the lack of access to health services and shortages of resources for the provision of healthcare along the continuum of healthcare, and also the lack of or shortages of health personnel and especially specialists, health specialists, which limit the possibility of referrals within the health system. And then the other main issue, of course, is that of geographic access barriers per se, having long distance and time travel on the part of the users to move towards the health facilities, but also limitations on the part of the health providers to mobilize to the communities to provide community-based health services. So those three seem to be the main issues identified from the literature review. Next. So when we look at the results based on quantitative data, they also add a very complementary picture to what we see from the literature review. And so here in these results, we're looking at unmet healthcare need and the reasons why there are unmet healthcare needs for indigenous communities versus non-indigenous communities. And then you can see that for the indigenous communities, the issue of acceptability, lack of trust in doctors, and experience of mistreatment is the main driver of unmet healthcare need within these communities. They experience this type of access barriers in a much higher proportion than non-indigenous communities. Other issues such as accommodation, lack of time, long waiting time, and of course, geographic accessibility and financial accessibility are also experienced more frequently by indigenous communities versus non-indigenous communities. Next. Then when we look at the trends in this data disaggregated by different variables, and I would like to concentrate here on the geographic dimension of the data as well as the ethnicity, we can see that on the first part, the issue of acceptability, there seems to be an intersection, in which both indigenous communities and people who live in rural areas experience barriers related to acceptability, in this case expressed by lack of trust in doctor, in a much higher proportion than non-indigenous people or people who live in non-rural areas, in this case, Lima metro area and other urban areas of Peru. And then with regards of geographic accessibility, it is the same thing. You have, people within indigenous people, and people who live in rural communities, as well as poorer people experiencing these barriers more frequently than non-indigenous communities or people who live in non-rural areas as well. And the other important issue is that the absolute gaps between those different groups of the population doesn't seem to be closed when you look at the trends between 2003, in this case, all the way to 2021. And in fact, in the past 2 years of the pandemic, you can actually see an exacerbation of those types of barriers, particularly those that relate to the acceptability dimension of access, which is a very interesting point. Next. Then when we look from insights from stakeholders, and it's important to highlight that, this study was conducted with active participation of different actors within the Condorcanqui province, the healthcare network, as well as community leaders, indigenous community leaders, and health personnel who were participating along this study. And then from their insights, they recognize that the lack of cultural adaptation of the health service and stigma and fear and shame are main barriers that are experienced by indigenous communities. And then also the issue of availability. In fact, in the province of Condorcanqui, about 88% of the health facilities do not have adequate infrastructure for the provision of health services, and they lack enough human resources. But then again, the issue of geographic accessibility is very serious in this context. The province of Condorcanqui can only be reached by boats. And in fact, the mobilization from one community to another one can take up to 12 hours of commute time. So it is very difficult actually for both the community and the healthcare providers to mobilize between the communities. So geographic barriers are very, very prevalent and very important driver of access to health services within the Condorcanqui province. And then in terms of financial accessibility, the main issue highlighted was that of the cost associated with transportation, as well as the lack of investment to facilitate the provision of the services. Next. So I'm gonna now present the results on Guyana, and I'll try to be a bit faster. Next. So in Guyana, the emphasis was on maternal and child health services. And then again, from the literature review, the main issues that are highlighted are those that relate to acceptability dimension, again, cultural notions, and then the taboos and gender norms that limit the search for maternal and child health services and reproductive and sexual health services as well. And then the other issue, which is very important in the context of Guyana, and especially in the hinterlands, which are the interior rural of the country, is the lack of infrastructure, essential medications, and human resources, which is actually one of the main crises within the country to the provision of health services, as well as low health literacy that undermines the search for health services, as well as financial accessibility, even though the country does offer free services at the point of service, at the point of provision. I'm sorry, these communities still will experience financial barriers as well. Next. So when we look at the insights from health officials, they definitely highlighted the issue of geographic accessibility more frequently than any other dimension, as well as acceptability. So it is very, it's a very important driver in the facilities being too far, or the lack of transportation to the health facilities, or for referrals, were the main issues that health officials highlighted during the interactions that we had, as well as the issues of acceptability, being that women, they prefer traditional or folk medicines, language barriers, and cultural and religious taboos. It is important to highlight that also in the hinterland, and Ernesto was mentioning this in the introduction, in the hinterland regions, they tend to have a very high proportion of people who are indigenous groups. So therefore, this issue of acceptability, it becomes very, very relevant within these communities as well. Next. And then with regards of the data in Guyana, was a little bit more limited because data was only available for 2009 from the DHS surveys. However, the data, it complements very nicely with the results that can be obtained from the literature review, as well as the input from health officials. So, distance to health facility, financial accessibility, and also demands high barriers, as for instance, the women not wanting to go alone to the health facility or having to ask permission to seek for healthcare. They tend to be more frequently experienced by women living in rural residence, as well as poorest women. And in the case of having to ask permission to seek for healthcare, they are more prevalently experienced by women who are who do not participate in household decision making. So you can again see this pattern of the intersection between being in rural areas and being poor and experiencing different types of access barriers that limit the use of these important health services. Next. So, from the two case studies, I guess we can highlight that the issues of availability, geographic barriers are very important, but then it's also the context of the people who live in these areas, them being the majority, especially in Peru, indigenous communities. It calls for the need to adapt health service provision. And therefore, in both cases, health officials, they recognize the need to strengthen primary health care to improve access in these rural communities, I guess with different highlights in terms of the specific policies that were recognized and identified through the exercise. So in the case of Guyana, for instance, they put a lot more emphasis on the need to expand the capacity of first level of care facilities within these communities, because there is a big lack of infrastructure and health personnel, and therefore there needs to be more investment just to increase the offer of health services within the hinterlands. And then, of course, the utilization of health prevention and promotion strategies to educate the population and to boost access to maternal and child health services and other essential health services was also identified. Then in the case of Peru, because the study was conducted in the province of Condor County and 95% of the population there are indigenous communities, the need to the intercultural adaptation of health services was very much highlighted and prioritized as a need for improving access to health services, as well as ensuring the active participation of indigenous communities in the decision-making process and in the planning of the provision of health services, as well as the need to adopt a more holistic and intercultural approach to health promotion that, considers the perception and upbringing of these communities, indigenous communities, to then adapt the provision of these types of services. And then, of course, improving also investments, because as I mentioned, in these communities, there is also an important lack of infrastructure and health personnel for the offer of health services per se. Next. So I just want to finalize our presentation with these pictures of these, in this particular case, are the people from the province of Condor County, and then my favorite is the picture with the poster, in which you can see the little cartoons are all the different dimensions of Tanahashi. It was a real pleasure to see them talking about all the accessibility dimensions and recognizing what are the main important drivers of access within the community. So thank you so much. Over to you.
Absolutely excellent. Thank you so much, Natalia and Ernesto. That was really a pleasure to see. And I think you really underlined how essential this kind of research is in the context of PHC strengthening in light of the insights that you got. And also with regards to the insights on intercultural approaches. I think that using methods such as you did offered evidence on intercultural approaches and the scope for them and the need for them that I think maybe other data sources wouldn't have been able to do as effectively. So thank you very much for that. And now I would like to go to our next speaker. And this is Sneha Kotian, who is going to be projecting her slides, I believe. And Sneha Kotian is a medical doctor specializing in community medicine. She is a Rural Seeds ambassador in Wonca's South Asia region. So Wonca being the World Organization of Family Doctors South Asia region. The focus of her presentation today is on participatory rural appraisal. And this is based on her postgraduate experience while working in the rural and tribal areas of Western India. Thank you and welcome, Sneha. It's an honor to have you with us. Over to you.
Yeah. Thank you so much for that kind introduction. A warm welcome to all the participants. It's my privilege to share this experience on this topic, demystifying the barriers in health services in rural areas using the mixed methods research. So this will be the flow of my presentation, a brief introduction to the topic, and this will be followed by a case study illustrating the use of participatory rural appraisal. I'll also be sharing my overall experience in the process of conducting it. So let's begin. So when we talk of rural areas, particularly with regard to research, a fuzzy image is created of a resource-limited settings. The most common question is, where do we begin from? What should be targeted and how do we go about it? So this dilemma often traps us and makes us deviate from the needs of the rural population. As we all know that complex problems demand innovative solutions, a combination of research methods could actually help in tackling such situations. So this brings us to the concept of mixed methods, as Theodora already introduced us. It's a collection of analysis of both qualitative and quantitative data in a single study. And the sequence of data collection could be either sequential or concurrent with the ultimate aim of integrating data. So coming back to our complex rural scenario, these mixed methods can actually provide the complete picture and help us in overcoming the limitations associated with these individual methods. So let's dive in deeper. So here is our rural, or you could say a tribal problem from a small western state in India, with the open defecation being a key challenge. So this case study basically highlights the use of participatory rural appraisal as the first step in involving the rural communities in assessing their needs and also planning meaningful community development strategies. So the crux of of the project was to address the social determinants leading to open defecation. So what exactly is this participatory rural appraisal? So it's a method to involve the community in identifying their needs and also implementation of solutions based on their ideas. So in simple words, I would say it is for the people, by the people, with the people. The first step in this process was to understand, so to begin with, the first step in this process was to understand the situation and to identify the local key stakeholders. And this included your village heads, the health workers, religious leaders, and other important representatives from different fields. Building a really good rapport with these stakeholders is definitely an essential element for the smooth functioning of the project. And during this process, we also narrowed down the issues relating to water, sanitation, and hygiene. So after the initial groundwork came the actual field work, where the project area was inspected with the help of a transect walk to understand basically the village structure and also the available resources. So finally, the issues relating to water, sanitation, and hygiene were also noted. Then came the social mapping, and in this process, the rural communities themselves were involved and they were asked to draw the maps of the areas, highlighting the major landmarks and as well as the accessibility. This helped in reflecting about the infrastructure and the socio-economic demographic details. Once the mapping was done, the process of listing the problems relating to water, sanitation, and hygiene began. So these included your open defecation, the absence of a proper waste disposal system, absence of water purification at source, which also included your water handling techniques, then poor connectivity to roads, as well as some street lighting issues. The picture in the corner which you see is actually an area of the open defecation spot, and besides that was the bathing of the community where bathing was carried out. So after listing of these problems, prioritization of these problems was done by the rural community members themselves, and it was divided into 3 groups based on the actions needed. So these categories included your immediate actions, then the next category was the ones in which the targeted actions could be done within the next 6 months, and lastly, the ones which could fit into your long-term plans. Based on this data obtained, this was also collected during our group discussions and then finally fine-tuned to our focus group discussions. So finally, based on the data obtained from this exercise of participatory rural appraisal, the cross-verification as well as the validation of all the data collected was done, and secondary data analysis from the existing resources was done. That is all your quantitative data from the existing rural local regulatory bodies, and it was used in triangulation. And lastly, this information was used to develop the next plan of action. All this said and done, this process did have its own strengths as well as challenges. It was definitely a good community building exercise in the rural community. The local knowledge was actually put to good use, and it also helped in generating livelihood activities by actually tapping the local resources. By this, I mean, when we realized the problem of water, sanitation, and hygiene, the first step was to start with the process of building toilets because this area was 100% open defecation. So there were a lot of seasonal workers in this rural population who would actually work as construction workers. So that pool of resources from the community was actually tapped in building toilets. So basically, it built in a sense of responsibility, ownership in the process. And the process also had its own challenges. Though the process of PRA as such is quick, the process of building trust and good rapport definitely takes a lot of time. And we also had a lot of difficulties in the initial stages to get everyone on board. But in the end, I would say it was a really fruitful exercise. So in conclusion, I would say that participatory rural appraisal is an effective tool actually to explore the rural areas for the different problems. Also, complex problems in rural areas may not always have concrete solutions, but with starting points like the participatory rural appraisal, it can be moderated. So that's it from my side, and thank you. And please feel free to get in touch for your comments or any suggestions or points for discussion.
Thank you so much, Neha. That was really, really interesting. And hearing the process that was undertaken with regards to the planning involvement of local stakeholders, the transect walk, the social mapping, really involving the community members, and the problem inventory. I very much appreciated the immediate, medium, long-term planning, how the inventory fed into those. And then the group discussion and the focus groups that then follow to that. I think that's a very interesting and relevant process that you've outlined for us. So thank you very much. And I'd like to now go to our next speaker, and that is Luc Schaeffer, who is the Herman and Amelie Kahn Professor of Social Justice and Social Policy at the Gerald Ford School of Public Policy at the University of Michigan in the United States. And he is also the director of Poverty Solutions, a university-wide initiative that specifically aims to partner with policymakers and communities to find new ways to prevent and alleviate poverty. And Dr. Schaeffer's presentation will introduce an iterative mixed method study that explores the roots of deep disadvantage in a number of the poorest communities in the United States. So I'd like to now hand over to Luc. Thank you.
You can go to the next slide. Hello, everyone. It's really a pleasure to be with you, pleasure to be with people all over the world thinking about these important challenges. I'm going to talk about a project that I collaborate with Kathy Eden and Tim Nilsson from Princeton University that received funding from the Robert Wood Johnson Foundation that we're very grateful for. We engage in what we call iterative mixed methods exploration in our work, where we try to bring quantitative and qualitative analyses and insights into conversation with one another. In this particular project, we began by trying to develop a multidimensional index of deep disadvantage to identify the most vulnerable communities in the United States across multiple dimensions. I'll talk a little bit about that. After we had developed this index and been able to rank counties and cities all across the country on a continuum of disadvantage, we embedded researchers in some of these communities to collect deep ethnographic data. And of course, one of our main findings was many of the concerns and issues that we went in thinking would be the primary things we would study and write about and learn about often weren't. So in fact, we often say sometimes we don't even know the right questions to ask from the outside. In the end, the primary purpose of this project is to paint a vivid portrait of the conditions and social and physical environment in a number of the nation's most vulnerable communities, and to uncover contextual factors that may drive disparities. You can go to the next slide, please. Our goal with our index was to define and predict community level disadvantage. And we really wanted to try to rank communities across multiple dimensions. Often in poverty and hardship, even in health data, we spend a lot of time arguing about the measurement of any one indicator, the shortcomings, what it tells us, how it should be changed. And we do that a lot in the United States. We wanted to try to bypass that debate and say that we know that disadvantage is manifested across multiple dimensions. And also by using a number of different dimensions of disadvantage, we could buffer ourselves against the weakness of any one measure if they paint a consistent picture that would strengthen our confidence that we had really gotten it right. And this also allows us to be sort of more flexible. We can use many different sorts of data. So we ended up using a statistical technique called principal components analysis. Again, here we're collecting data on communities rather than individuals, and using principal component analysis basically look at patterns across all of the different types of metrics that we have drawing from many different places. Next slide, please. For our principal component analysis, we thought of 3 dimensions that have particular salience in the United States. So I might imagine in different parts of the country that these might look different. We thought of income or resources, so you could think of that as income or consumption or expenditures, a way of sort of assessing the money that's coming into families. The data we were able to access is from the American Community Survey. This is sort of the data available in the United States for low levels of geography, the percent below the income poverty line in the United States and the percent below the deep income poverty line, which is about half of the poverty line. Then we were able to take life expectancy data and data on births with low birth weight. Finally, for mobility, there's a set of administrative data in the United States that uses tax filings historically to see what are the fraction of children who grow up in low-income families that reach the median income in adulthood. So as you can see, we are taking sort of 3 different dimensions: resources or income, health, and social mobility, and putting them into sort of one metric overall, right? Trying to look at the associations across them and rank communities thereof. Next slide, please. When we do that, we are able to put communities on a continuum. And in this map, you can see the darkest blue areas are the ones that have the most disadvantage across all of these dimensions. And the lightest blue are the ones in the United States that have the least. And when we look across many, many different measures, we didn't include inequality in our index, but we find that the most disadvantaged communities in the United States are also the ones that are the most unequal. We find they're the lowest educated, that they have the highest rates of unemployment. Pretty much any indicator we've looked at sort of splits in much the same way that we see in this map. Another defining feature of this map, and something that surprised us, not being folks who went in with the intention of studying rural poverty, was how predominantly rural the most disadvantaged places were. So when we look at the 100 most disadvantaged places across income, health, and mobility in the United States, only about 10 of those are cities. And the remaining 80 are rural counties, and then there are some somewhat more urban counties in the mix. So predominantly, the most disadvantaged places are also the most rural. You can see that it splits out on this map into about 3 regions. If you look sort of in the southeast, you can sort of see a U shape. That's the cotton belt of the southeast. Up a little further is Appalachia, which would be in eastern Kentucky. Down in South Texas on the border. And then if we look out west, we see pockets of deep disadvantage, which are primarily tribal lands for Native American communities. And what's striking about this is that these clusters, if you will, have deep historical roots. If we go to the next slide, we compare our map of deep disadvantage, just zeroing in on the southeast region, to a map that was produced in 1860 of the concentration of enslavement in the United States. And you can see not only do they have sort of a similar pattern, the grading of the maps is quite consistent across the two. And in fact, when we use a regression model to predict disadvantage in the 21st century in the United States, we are able to predict with quite a bit of precision that simply based on the rate of enslavement in 1860. So this told us a lot about the importance both of focusing on rural communities, which are deeply understudied in the United States, and also understanding how much history matters. In much of research on poverty, I would say we often have a nod towards history, but don't spend really a lot of time thinking about how it shapes. So I wanted to just quickly bring out one theme in the qualitative work, and that goes back to this theme of sometimes not even knowing the right questions to ask. When we started doing work in the PD region, which is sort of at the easternmost tip of the U in the Cotton Belt, that sort of southern cluster of deep disadvantage, we were prepared to talk about education. We were prepared to talk about jobs, and the biggest thing on people's minds was disaster recovery. So we were in Marion County, South Carolina, which was a place that when we were starting our field work in 2019 there, had suffered a massive flood in 2015, Hurricane Matthew in 2016, and then Hurricane Florence in 2018. And in Marion County, many of the towns sort of sit near the edge of where two rivers meet. And so these places are extremely at risk of flooding. But beyond the crisis and the trauma of the flooding and experiencing water going up, halfway up the side of houses and people being trapped on the top of their cars or on their roofs, the thing that really came up was the extent to which systems that were meant to help families when they experienced something like that really did not work well for low-income residents. So if you'll go to the next slide, we'll just have sort of two pictures. The first thing is that in a lot of these rural communities in Marion County, we were in Nichols and Sellers. The government came out and was able to sort of identify houses that were no longer inhabitable or that were inhabitable. This is one of the ones that was identified as being inhabitable. And there were people living in the house when we were there. But then after that, many of the community members identified significant challenges with accessing any help at all. One of the main drivers of that was clouded title. So families who had been paying property taxes for many, many years, but had not gone through sort of formal processes of inheriting a property from their families, rather it had just been passed down from generation to generation, they would be disqualified from receiving any government assistance. And in the United States, a huge fraction of Black families, especially in the South, have passed property on in that way. And so we're either barred from being able to receive any help or had to go through significant, additional bureaucratic processes to access that help. Literacy obviously was a major challenge. The programs to receive help were, very difficult to navigate. Missing appointments for someone who doesn't have sort of resources to be close by to meet an official. And then finally, questions of monetary value. So in many cases, households might be by the United States standards deemed unlivable, condemned before the floods, would be ineligible for assistance. Yet many people still lived in those homes and actually had for generations. So by the time we were there in 2019, if you could go ahead 2 slides, I would say, we met many families who were actually still living in households, and you can see here, sort of very clearly where the water line went in this household. This is one that, was under sort of perpetual construction. Families had no chance of moving back in, but other people who we met with actually lived in fairly similar conditions, such that as we walked in, you could really sort of feel, you could immediately be affected. And there was a lot of evidence to suggest these had rippling health effects. Obviously, one of the residents who lived in a house where the walls looked similar to this had just received a pacemaker for trouble that had emerged after the floods. So if you go to the final slide, we didn't really think that we were studying anything when we started this project on disaster relief or climate change. But as climate change intensifies in the United States, communities in the Southeast can expect to be hit by extreme weather events more frequently, and that includes extreme floods, as well as extreme drought. And disaster relief programs are slow and sort of low-income residents poorly, so much so that when there's a new study out that finds when places where FEMA aid is distributed, when we look at these families compared to other families that were not impacted, white families in places where FEMA aid was distributed saw their wealth increase relative to similar white families in unaffected communities. In contrast, Black families in these places who received FEMA aid saw their wealth decrease compared to Black families in other places. So we have a set of policies that certainly don't reduce inequality, certainly don't even keep it sort of stable, but actually exacerbate inequality. And these are rooted in long-term dynamics of structural inequality and structural racism. Thank you for the opportunity to talk with you today.
Thank you so much, Luke. A really, really important study that you've shared. I was struck by your reflection that external researchers may not even know the right question to ask from the outside. I think that that's something we need to constantly remind ourselves, and why we need to use participatory approaches as a way to really cross-check. Are we asking the right questions for the communities that we're trying to help? And then also the issue that you've raised on the historical drivers of inequalities, and I think that this is critical. And I agree that often in our fields we don't look enough at history, and there's sometimes a desire for quick fixes that neglect the fact that the drivers, some of the drivers that need to be challenged are rooted in 200, 300 and more years of history. So I appreciated that very much. And then finally, the use of the map, I think, it's a very strong policy tool, and how we bring in maps and data visualization into mixed methods, I think is really important, and use them as part of our storytelling. So thank you. I'd like to now go to our next speaker, who is Ana Lorena Ruano. And so Lorena is a researcher at the Center for International Health at the University of Bergen. Her work uses a human rights approach in the study of equity in health, particularly Indigenous health and health system strengthening. And she will present on bottlenecks and opportunities to have data on rural health used in policymaking and programming, and offer wider reflections for data use. So over to you, please, Lorena.
Thank you very much, Theodora. It is my pleasure to be here today. As Theodora kindly mentioned, my name is Ana Lorena Ruano, and I am a woman of many hats. I am a researcher at the Center for International Health, but I am also the managing editor for the International Journal for Equity in Health, and I am the research and learning coordinator for the Center for the Study of Equity and Governance in Health Systems. And so I was asked to come here today to talk about overarching issues, and I was very happy to see that, particularly happy to see that the issues that I had thought to discuss were reflected in the presentations from my colleagues today. Could I go to the next slide, please? So I thought that I would begin my presentation with a little bit of where we are right now. And all over the world, we see that the extreme poor tend to live in rural areas where they're disconnected from most state-run services. And then they face compounding multidimensional challenges to living a happy and healthy life. And we have also seen from the presentations of our colleagues, but also from data from our own countries, that people that live in rural areas tend to be indigenous, or tend to belong to, or to marginalized or traditionally excluded ethnic groups. And so this really puts an onus on us really understand what their burden is and how it's been shaped. And I was very happy to hear Luke discuss the importance of historical understanding of how these processes and these communities came to be where they are. So in my work in Guatemala and in what I see from the journal, there's a general misunderstanding of the experience of what being poor is, and then a general misunderstanding of what that experience is in a rural area versus an urban area. And this is because, like as Luke mentioned, there is very little or there is no knowledge on the social, historical, and economic processes that led to the exclusions of these populations living in rural areas. And this little knowledge is not with the communities, and it isn't with us, the researchers, and it isn't with the policymakers. So this means that we're implementing policies a little blindly, and we're not sure if what we're doing is contributing to exacerbating existing inequalities, as we see with FEMA. There is also little or no meaningful participation from these communities or from their leaders. And this contributes to us not being able to ask the right questions in the right way, to the right people. And so I was very happy to hear about the importance of participatory action research. And as we heard from the experience in India, building trust takes a really long time. And it's not very easy to go and do participatory action research or rapid rural appraisals if there is no existing relationship with the communities that we want to work with. There is also poor or non-existing links between urban and rural development, where we see a focus on urban areas because they're easier to access, but they're also easier to let other people know that we were doing. So governments are better able to publicize what they do in urban areas, and citizens are better able to witness that there is development happening in urban areas versus rural areas. Could I go to the next slide, please? And so in the end, we come to a disconnect between what is useful information according to communities and what is useful information according to policymakers. And this leads to a plethora of issues that not only impact communication, but also leadership, participation, and health system governance. Could we go to my next slide? So why does this disconnect exist? Well, reflecting on it, I think that there are two sets of issues. There are systemic issues and there are practical ones. In the systemic issues about the disconnect between what rural communities want or need and what policymakers are doing, is that there's a lack of infrastructure and human capacity to gather and analyze the data. And so gathering quantitative data is very important. We need to know the things that we can only learn from quantitative data. But do local health officials, do local policymakers and decision makers have the capacity to analyze this data? And this is something that we find that is lacking in several contexts. And we see many universities, including my own and my center, focus on building these skills among policymakers, but maybe these skills aren't being built in civil society or among leaders. So how can we understand what the data is really telling us? There's also a focus on the right kind of data. And this kind of data tends to be quantitative, thinking that if we have several surveillance DHSs, if we have several surveys, if we have the census that are very, very sensitive and have all this information and we can run all these models or regressions, that we'll know what's happening. But when we only focus on quantitative data, we're missing the human dimension, and we're missing an opportunity to understand if we're gathering the type of data that is needed, not just the kind that we think is right. And then there is a structural inability to tackle complex and wicked obstacles. Part of this is from the disconnect or from the basic misunderstanding of the historical processes that brought us here. On the side of the practical issues, policymakers are overburdened. People that work in research, people that work in civil society, and people that work in the government are overburdened with work. They have a lot to do, and then asking them to analyze, to gather, to analyze, and to integrate all that data is burdensome. There's also the problem of upward accountability traps, where governments and local health facilities or local health districts are forced to collect this type of data that is useful for the donors that gave them the money, but not necessarily for them, and it doesn't generate actionable information. And without actionable information, neither communities nor policymakers nor researchers can really go and act. There are also national policy goals that are not necessarily shaped or that they cannot reflect the local context. And I think my next slide, I think this is my last one. No, yes. And so how can rural populations and their data be put at the center of development? And I was very happy to hear about how much participation was brought up. Communities, rural and urban, indigenous and non-indigenous, have leadership inside them. They have structures for leadership inside them. There is a desire to work together. And so it is important for us to reflect on the level of participation that we're fomenting or that we're promoting. If we're really just asking communities to participate in a tokenist way, or if we're actually doing the work to empower them and give them enough tools and enough capacity to co-decide with us, to co-produce the policy with us. And so I think that is the biggest understanding or the biggest learning that we've had in the experience in Guatemala, is that in order to make communities and organized civil society an active participant and equal participant, there needs to be a process of awareness raising, of consciousness raising, where we understand together and we work through the historical, social, political factors and how they led to where we are now. And then how we build leadership and capacity in communities, and how we build the ability to accept and work together with these communities in health facilities as well, and among policymakers. That's it for me. Thank you very much.
Lorena, thank you so much. That was great. I just wanted to touch on a point you raised regarding the poor and non-existent links between urban and rural development. And this is coming up and has come up consistently in our work, and even an understanding of the, let's say, the cyclical migration patterns between the rural poor and the urban poor, and the need for services to properly actually respond to that. I think that this is an under-researched area with regards to these links between urban and rural development, and then also the rural poor and the urban poor that we need to do more on. Then also a point you raised was the national policy goals that are being shaped in ways that do not account for local rural context. And there, it made me think about the movement towards rural proofing. And so ensuring that national health policy strategies and plans are actually taking into account systematically the needs of rural populations, but also within rural areas, the different subpopulations to account for the heterogeneity of the rural population. And so thank you for first explicitly calling that out. And it is an area, the rural proofing of national health policy strategies and plans is an area that WHO will be doing more on. And then finally, when you showed the ladder, the participation ladder, and emphasized, the need to really go towards enabling communities to co-decide and co-produce, the higher levels of the ladder. I think that's a really critical point and very much in line with a human rights-based approach to development. So thank you to all of the speakers. I would like to now hand over to particularly Bruce Chatter, who is the chair of the Wonca Working Party on Rural Practice. And as I mentioned in my opening, Wonca has been an excellent partner for this webinar series. And please, over to you, Bruce, for the closing remarks. Thank you.
Thanks, Theodora, and it's been an excellent group of presentations tonight. Thanks very much to our speakers. I think you touched on at the start some of the disadvantage that there is in rural areas around facilities, around service, around affordability, around access and acceptability, around gender issues, and particularly about respect and engagement of local people. And I think that's really come through tonight. I think we've seen that real disadvantage is predominant in rural areas, both in lower and middle income countries, but also in high income countries. We've seen that even in the United States, obviously a very rich country, there's 80% of the extreme poverty is in rural areas. How do we get around this, and how do we approach it, and how do we improve the health of people? I think there's a tendency sometimes to look at the quantitative data and say, well, let's look at what we can measure. And I think we've seen tonight that we can dig down a bit deeper than that, not only by getting better quantitative data, but also getting the qualitative data, and seeing what people want and need in rural areas, rather than just the metrics that we can measure. I think it's so important to get those rural insights, and certainly as rural doctors, I've seen a bit of comment here about particularly rural doctors and other health professionals, and we join with our colleagues, our nurses and community health workers, who are really a bit of a link there, in that we often come from very privileged backgrounds, that we have good education and we can understand a lot of the policy issues, and even the research issues, and often are linked back into universities. But we're also deeply rooted in our communities. And I think you could see that very much in Sneha's presentation, about actually seeing what was important for people in those communities, about water and sanitation, about those key things that are important to the people in the communities and in the rural areas. So I think we're very pleased to be in partnership on this series, because I think as rural doctors, we bring those insights that can probably help our research colleagues, but also help the communities in which we live and serve. So it's nice to see a great group of researchers, and also a great group of rural doctors and rural health professionals on tonight. I hope you've all enjoyed the evening and gained some insights. We've got our next webinar series, or next one in the webinar series, is about rural women and addressing inequalities in health service coverage. That's on the 17th of February. That's a Thursday. Be the same time that we've got with this webinar. And I think that one coincides with International Women's Day. We've had earlier on the Rural Women's Day. And then finally in the series later on the 24th of March, we're going to be looking at innovations. And I think that's really important, that we're not just talking about the difficulties and downsides, but certainly in rural Wonca, we've very much looked over the years at how we can improve things, how we can get more comprehensive services through generalist practitioners, both doctors, nurses and others, who can serve those rural communities. So we're looking at those innovations on the last of the series to try and get some greater equity in rural and remote areas, especially in lower and middle income countries. So thanks very much for joining us. It's been another wonderful step in this series. And I'll just hand back to Theodora to say a final few words. Thanks, Theodora.
Thank you so much, Bruce. Excellent. So I'd like to thank all of the speakers really for the great presentations, and also all of the participants. And thank you also for your comments I see in the chat. Very insightful. And With regards to our next webinar, it's actually in the lead up to International Women's Day. In that day is actually on the 8th of March, but we're celebrating with this webinar on the 17th of February, just as the lead up and a bit of the sensitization on around these issues from the rural women's perspective. And I wanted to particularly thank Wonca for the partnership for the series, as well as OECD, who's collaborated for some of the webinars, as well as agencies of the United Nations Inequality Task Team, in particular, the subgroup that focuses on rural inequalities. And a final thanks to Pramila, who is the behind the scenes key person, getting all the presentations in order, arranging all the online aspects. So we really appreciate her excellent work in making all of this happen. Thank you, Pramila. And then just housekeeping wise, all of the presentations will be put on the WHO website and also accessible through the Wonca website. And we encourage you to, use them, download them, and really, let's say, help spread the information and use this whole series as a resource for sensitization on these issues, and potentially also, capacity building. Share them with your students, those who work in academia, so they can be referenced in documents. Please help push this forward. And at the end of the series, we'll be sending out a note to all participants with the full links to all of the editions, all of the webinars, and then you'll see how to download any of the presentations as well. And the recordings, the live recordings, will also be posted online. So thank you again for everyone's participation, and we will see you at the next webinar in the series. Thank you so much.
Thank you.
Bye. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Bye-bye.
Bye-bye.